Okay.
Yeah, start.
We'll start.
Okay, go ahead. We are live now.
Okay. So, first of all, good evening, everyone. And it gives me an immense pleasure to welcome you all for this webinar on cruciate retaining versus posterior stabilized knee. It has been a great initiative and a brainchild of Dr. Parag Sancheti to have this webinar in association with the Asia Pacific Arthroplasty Society and Sancheti Hospital. Actually, it's an endeavor to discuss most of the controversies around the knee arthroplasty, and we will be inviting surgeons from India and around the world to elaborate and solve the dilemmas which we face in knee arthroplasty. So nowadays, the majority of the people are doing posterior stabilized knee. However, with the advent of newer advanced poly designs like the lip, deep dish, ultra cognate, there has been a paradigm shift with CR knees, and it has been towards cruciate retaining knees. It is considered to be more natural and replicates the anatomy better. That's what has been contemplated. And these are, there is mostly a talk of biology and mechanics rather than only mechanics, which was earlier the discussion. Now, question is, there have been implant designs which have come up with cruciate retaining, like bicruciate retaining, single cruciate retaining. But the question is whether to sacrifice both, whether to sacrifice a single one, or just not to sacrifice any one of them. So today we have stalwarts in the field, Dr. Nicholas Buddhiparma, Dr. Ashok Rajgopal, Dr. Bharat Modi, and Dr. Parag Sancheti, who will be guiding us towards the light at the end of the tunnel, and what we can do with these questions. And I would like to invite Dr. Sunny Google, who will be introducing us to this August faculty. Over to you, Sunny.
Yeah, thank you, Kailash. I'm sharing my screen. Yeah, I've been given the job to introduce our star faculty. Our first faculty today and the moderator of our session is Professor Nicholas Buddhiparma. I would like to congratulate him on taking over as the APAS president. He is an Indonesian orthopedic surgeon with a specialty in joint reconstruction, and he completed his degree from Netherlands. Professor Nicholas holds a lot of executive posts. He is the current president of APAS. He is the current president of Arthroplasty Society of Asia. He is the current president of Asia Pacific Knee Society. So a lot of feathers in his cap. We will welcome you, Professor Nico. Our next star faculty is Dr. Ashok Rajgopal. He is a Padma Shri awardee from the Government of India in 2014. He has also achieved the BC Roy Award in 2014. Dr. Ashok Rajgopal is the chairman of Medanta Institute and is the chief orthopedic surgeon there. He has done around more than 35,000 joint replacement surgeries, and he has delivered nationally and internationally in all the conferences. He's on the editorial board of the KSSTA Journal and is a reviewer for JBJ's British volume. We welcome you, Dr. Ashok Rajgopal, for this webinar. Our next faculty is Dr. Bharat Modi. He is the chief orthopedic surgeon at Wellcare Hospital, Vadodara, and he has an experience of more than 25 years in orthopedics with a special interest in hip and knee arthroplasty. He is the member of the scientific advisory committee of the EFOT Congress. He was the vice president of APAS in 2018. He is the past president of Indian Arthroplasty Association in 2015. We welcome you, Dr. Bharat Modi, to this webinar.
Thank you.
I would hand over to Professor Nico to start the debate.
Yeah, before that, just a quick word before Nico takes over. So thank you, Sunny, and thank you, Kailash, for setting the platform and set the ball rolling. So I think it's going to be a very interesting debate, if I may say so, on CR versus PS, and we have the best of faculty in the world, I would say, because both are very passionate of what they do. I have seen Dr. Ashok Rajgopal. He's no longer at Medanta, but he has moved to another hospital. At that time, when I saw him, I had gone to meet him at Medanta Hospital, and as luck would have it, there was a stiff knee posted. He invited me to the theater, and I said, now is the chance when Dr. Ashok Rajgopal is going to sacrifice the PCL, if at all it's there, and going to do a PS knee. But I was amazed that he maintained the PCL and did a CR knee. And even with that stiff knee, he could manage to put in a CR knee. So that's amazing, sir. I still remember that case, and that shows his passion. At the same time, I have seen Dr. Bharat Modi, who is also equally passionate about PS, and he can really do a fantastic knee. I saw him operate at Ganga Hospital when I was moderating his surgery, and he did a fantastic job with the PS. And he's an ardent follower of the PS. So both in their own ways are, religious for CR and religious for PS, if I may say. It's more of a religion. But I don't know today what's going to happen at the end of the webinar, who's going to get converted. Let's see. Bharat would probably not get converted, and definitely not Ashok Rajgopal, but let us see what comes out. I'm very eager to hear this debate. And I really thank Dr. Ashok Rajgopal sir and Bharat Modi for having accepted to be the faculty for this. It adds value to this first ever APAS webinar. And we also have my brother and good friend, the president of APAS, Professor Nicholas Budiparma, take over as the moderator. He has also given talks, and I've heard him speak in APAS conferences on CR versus PS, and he has a perspective. So over to our very new, brand new president of Asia Pacific Arthroplasty Society, under whose aegis this webinar is taking place today, to tell us a little more about PS and CR, and then we will have the stalwarts tell their story. Thank you very much.
Thank you very much, Professor Parag Sanchetti. First of all, I would like to thank Sanchetti and OrthoTV. They help a lot to broadcast all the about education for all over the world. Thank you very much, Parag. And and it is an honor for me to becoming the president of APAS 2 weeks ago, and start day 14 now. Parag arranged this meeting for the education wise, so I think it's very helpful for the members of the APAS. And thank you very much. And besides that, today we will have a debate. Actually, it is, I don't know how to say it. It's it's a sensory debate. Every time you go to the meeting, there's a debate about the CR or the PS. And it depends on where you train, then who is your teacher, and what is your experience. My question now is whether Professor Rajgopal can change mind of Professor Modi to use a CR. I would like to hear that. Otherwise, if a debate is a normal debate, that's what I would like to hear from both of them. And both of them is a world-class faculty. I know them about 20 years ago. That and they are very, very amazing, and especially when they do the debate. So it's an honor for me to moderate both of the world-class speaker. Now, for the first, may I invite Professor Ashok Rajgopal to talk on the CR, please.
Thank you, Nico. And let me start by thanking Kailash and Sunny and my very dear friend Parag and Ashok Sham for this wonderful platform. Congratulations officially, Nico, on taking over the presidentship of the Asia Pacific Arthroplasty Society. And a very, very warm welcome to my very dear friend Bharat. I think I'm going to go out of my way to be nice to him today. So gentlemen, have a look at this first opening slide. The slide to your left, which I trialed with a primary implant, and the same knee that came to surgery 14 years later for a periprosthetic fracture. I think end of story. I don't need to go any further. I think the debate is over.
Yeah.
Right. So when I say worthy adversary, I mean it. Bharat, apart from being a very dear friend, is a very, very accomplished orthopedic surgeon. Just got his facts a little bit mixed up at the moment. And I hope, by the end of this debate, he will come back on track and learn to do what is right. So this is like Nico said, one of the perennial controversy debates and discussions. Should you sacrifice or retain? My conviction, like Parag said, it's my religion. Retention suffices in most cases, requiring knee replacement. So what are the primary concerns? Can you trust it? Is it reliable? Does it have long-term predictability? You need to be over fussy, and is it a demanding procedure? So let us look at the following points. What is the anatomy? What are the kinematics, the functional outcomes, the flexibility and deformity correction? Can you use it only in minimally deformed knees? What are the fixation options? What happens in terms of longevity? One of the criticisms is you get latent stabilities. And what does the literature say about it? I think pretty much I can preempt what Bharat is going to say. And if you read through this, it pretty much summarizes really what the concerns about the PS knee is. There are also unknown unknowns, and these are things we don't know. This was by Donald Rumsfeld, who mentioned this in one of his debates. Now let's start by, why should we retain the PCL? First of all, I would like to say that it's present in over 96% of knees, including knees that have been fused for as long as 15 to 18 years. PCL retention improves functional range of movements and efficiency of the musculature, proprioceptive control. And when you look at long-term survival studies, it does not show a higher rate of loosening as was earlier preempted. And conforming designs today with better polyethylene has definitely does not lead to increased wear rate. The other point is with CR knees, because your PCL is retained, you don't get good exposure. Well, you do. If you release your deep medial collateral ligament, obviously you're releasing your ACL. And the important thing is an intact PCL actually absorbs forces at the cement bone interface. And it's a very good platform for cementless options. And I'll just tell you why. It retains bone stock. As I said, cementless option is a great alternative. And when you look at the gait analysis, the CR knee compares very favorably with that of a normal knee in stair climbing. And these are several reviews, and these are, I'm going back in time. I know we are almost 30 years ago, but even as far back, Merrill Ritter and his group, Andriakia, go back almost 35 years ago. And they all sort of, in their research, came out with the fact that the motion and the force plate analysis revealed very symmetrical gait patterns in the CR knees. Again, when you look at Johan Bellemans' work and his group, a relatively posterior position was significantly correlated with greater maximum knee flexion. And this is one of the so-called advantages of the posterior stabilized knees. And in doing so, certainly in some of the earlier options, you got posterior bone implant impingement as high as 28%. And this was possibly one of the reasons why it led up to the Clunk syndrome. Now look at this analysis. We did contralateral studies. This is our own study in our gait lab, left side CR and right side LPS. And when you see the gait line and the butterfly and the gait line on the right and the left, you have a very symmetrical pattern. And what this really shows is that the center of pressure analysis shows a more uniform distribution on the left side, which is your CR side, compared to the right, and a greater sense of stability. This was a blinded study. So the person who was doing the study did not actually have, did not have access to which knee had the CR or the PS, and this was completely blinded. So even in terms of heel strike and push off, there was more forceful lift off on the left side. Though in terms of statistical evaluation, this was possibly uneventful and not statistically significant. So where can we use the CR system? I belong to this school of thought. When you look at Dick Scott from Boston, Barnes, only 6 out of 3,000 PS, Ritter, even in very severe deformities. And certainly in our experience, we do it in almost 95% of all of our primary knees. When you look at survivorship, 98.6% at 15, 92 at 15, 97.2 at 15 to 17 years. So longevity is not really an issue. Now let's look at deformities. Look at this valgus deformity. Purists would say this cannot be done with a CR. Well, it can, and this is your 11-year follow-up. We have reported this in the Journal of Orthopaedic Surgery in 2011. We have reported a longer-term follow-up in seminars in arthroplasty. And we have presented this both at the American Academy and at the CORR meeting. Look at this windswept deformity, grossly unstable, What are your options? I think most people would look at constraint options, maybe LCCK, maybe a hinge. We chose a rather strange choice, which stood the test of time. We used a CR option, and this is a 14-year scanogram, which shows excellent outcomes, very good stability. And 14 years, there's no loosening. The grafts have incorporated well, and this patient has a functional knee. The ankylosed knee that Parag was talking about, we have several articles in literature, right from, we have 2 articles in JOA. And what this really tells us is, even in these really severe deformities and knees that have been ankylosed for over 12 to 15 years, when you go through and the intercondylar notch, you will find vestigial remnants of the PCL. So even in these cases, like Parag was telling, we were very, very happy and very privileged to have him with us. And we actually managed to demonstrate that even these knees have a posterior cruciate ligament. Look at this varus subluxation. This is a CR knee out at 17 years, functioning well. This patient has excellent outcomes, ranges of movements of almost about 115 to 120 degrees. Let's look at some malunited high tibial osteotomies. And this is again a patient, I was asked to operate this patient in Chennai. And people had actually organized for a RHK. We went on to do a CR, much to their disappointment. And this patient is now almost 20 years out and has done very, very well. Now, post-HTO, one of the so-called indications for a PS knee. Look at this patient. We reported this in the Indian journals many years ago with excellent outcomes. Let's go to yet another controversial PS biased indication, a patelectomized knee. Again, we have reported this in the journal. And we have now a series of, with a follow-up of almost about 17 years with patelectomized knees. And these knees have really done well with a CR knee. Look at the extra-articular deformities, and this is a segmental extra-articular deformities. You need to obviously choose your implants well. We've used one with a dovetail option with a drop rod, and this again has done very well, again been reported by us. When you look at joint line accuracy with the PS is the knee which is most of 6 to 9 millimeters, CR is 0 to 3. And you heard about the ACL PCL retaining, which is a very engaging concept, but really has not stood the test of time yet. There are several technical challenges, and knees that are available at the moment are being worked out in a very few centers, in only the designers. And I don't think we have cracked the code with retaining ACL and PCLs just yet. One way of doing it is to put in 2 unis, but that's not the subject of this debate at all. Now let's come to the most important, longevity. Look at this knee. This patient was one of my first knees that I did in 1988, 31 years. And this lady passed away about 4 months ago. And at the time when she passed away, these knees were functioning absolutely perfectly. This is an all polytibia. This is a Freeman Samuelson, and it's an uncemented all polytibia. The one on the right is a TM implant, 124 months, almost 10 years. Now we look at instability issues. And again, we evaluated this using MG2 and next-gen CR. So these are older prototypes at an average 12-year follow-up. And we did this by clinical and radiological examination. On one occasion, we had the choice of using histopath examination. We used the KT1000. In unilateral cases, we compared it with the other side, and in bilateral cases, the 2 sides were evaluated. And we took weight-bearing lunge views, and we followed the Holly Spotter, who is a very famous radiologist from the HSS New York. And these are her protocols that she's recommended, which is what we followed. And you can see over here, these are all 12, 15 years out, and you can see the PCL in virtually most of these knees. And you can see excellent. The one with the case 3 9-year follow-up. I mean, you can't get a better PCL. This is 9 years out. What we really came to the conclusion was, in this study, we could actually visualize 43 out of the 64. In the others, we could not because of the scatter effect. And we had to revise one patient because of periprosthetic fracture, and we excised the PCL and sent it for histopathology. And it showed a viable PCL with the neural fibers. So at the very least, it's an integral structure. Whether it's functional, it's hard to say, but it does function as a restraint and promotes rollback. So we also did another study, which we published in the Journal of Orthopaedic Surgery. And in this, we have almost 79% of PCL showed presence of neural receptors. And this is the patient with the periprosthetic fracture, and you can see viable tissue at the junction of the ligament and the bone interface. So again, to show that these are viable structures, they are not just a cord. This is our publication in the Acta Orthopaedica Belgica. We did this in 2011. And here is the example. I mean, this is a patient trial, and this slide below, 14 years later, when we re-explored this for a periprosthetic fracture, you can see the pristine condition of the PCL. So the more anatomic it is, yes, it is more functional, but it's also possibly more difficult to execute. So what is the art and science of PCL retention? Take care not to damage the PCL when you're resecting the posterior horn. Remove all intercondylar osteophytes and the posterior tibia. And most importantly, you have to reproduce the natural slope of the tibia, and it varies from patient to patient. It's not the same. When you're doing a balancing, make sure your tibial base plate does not lift anteriorly in deep flexion. The anteromedial tibia must be congruous under the femoral component. I like to leave that knee just a little loose so that internal rotation of the tibial construct must be possible with the femoral component in situ. And most importantly, reproduce the normal anatomy. You cannot use 3 degrees or 5 degrees or 7 degrees for every patient. Look at your lateral views. That is where you will get your PCL to function the way it's meant to be. Have a look through all these x-rays. You'll see the slope of the proximal tibia varying hugely. So you need to reproduce this in your lateral views. And if it is tight, well, there are several options. If you want to continue with your CR, you can release it either at the femur or the tibia. We prefer to use it on the anteromedial fibers of the intercondylar notch on the femoral side. That's a preferred option. You can also do it on the tibial side, but we don't have any experience of that. Now, finally, when you talk about registries, and this is really a big deal, when you check this, you'll find that the least revision rate happens in the CR designs. In this particular case, is the next gen, but as a generic group, a CR is the, and again, this is the 2011, it's been repeated 13, 18, they all are talking this exact same language. What I'm saying is that this has stood the test of time. And incidentally, today, I think 53 or 54% of all knees done worldwide are CR knees. So I'm often asked, am I a measured resection guy or am I a gap balancer? I'm neither. I just try to follow the fundamentals of surgery. And one of the great one of the great books that I swear by is the little book by George Perkins, which is called Ruminations of an Orthopedic Surgeon, where the starting 2 lines are, wisdom comes from years of experience often learned painfully. So let us go back. In our 30-odd thousand of primary implants, is it trustworthy? Yes. Reliable? Yes. Long-term predictably? Yes. Is it fussy? Yes. But then surgeons are meant to be fussy. Is it a demanding procedure? Of course it is. But then if you're not going to have a demanding procedure and demanding surgeon, you cannot expect good results. And finally, if you look at all the gurus, it's an interesting sort of twist of fate. And this is where I'd like to draw my dear friend Bharat's candid opinion. Some of the gurus have shifted from PS to CR, like in a lot of catalogs which sell expensive watches. It says names only on request, prices only on request. So I'm also going to say names only on request. But suffice it to say, some of the biggest PS users today are CR users. And finally, you can still do a CR knee on the femoral side. If for whatever reason you choose to sacrifice the PS, which I believe you don't need to, you still have the option of using a ultracongruent or now a medial congruent, which gives you excellent stability. This has medial stability, which is like the UC, and the lateral stability, which is like leading CR, and it's not dependent on the PCL. So at the very least, you can still retain your CR femoral implant, not take the box out, You're sacrificing bones not required. There are insufficiency fractures in small bones, osteoporotic bones. All of those issues can be avoided. The post-wear can be avoided. The clunk can be avoided. Dislocations can be avoided. And look at the contact area that you get with the medial congruent. And I'm just using the medial congruent and the persona because I was on the design team and I was actually responsible for the UC development. But this is absolutely excellent. And there are other companies which are equally sort of favorable outcomes. So finally, my convictions, I have had the privilege of working with the two Johns, the John Insall and John Charnley. Learned from them to keep surgery simple. And the longer I've done TKRs, the more convinced I am, and I will continue to be, is that retaining the PCL is my preferred partner. The occasional difficulties notwithstanding, occasionally having to take on very, very dear friends who are very close to my heart, like Bharat. So I don't want to ruffle his feathers too much. Finally, Bharat, this is my final preference. My preference is to go where I can see. I leave the choice to you. So good luck. I hope I've convinced you that the next time you see a knee, treat that PCL with respect, because the Society for Prevention of Cruelty to the PCL is getting very, very strong. It's becoming a global phenomenon during these COVID times. So you'd be well advised to respect the PCL, keep it on, and believe me, in the next time we have a debate, you will be talking about the CR knee and I'll be talking about the UC knee. Thank you all very much for your kind attention.
Thank you so much, Ashok. So, Bharat, you still want to continue or just give up?
Yeah. So I'll start with the last slide that Ashok showed. And I think intuitively he knew that talk had to go in the direction he showed, into that toilet, you know, the loo, which he indicated. And somehow his inner self recognized the truth as it existed. So Ashok, thank you for pointing out that talk had to go towards the direction of the toilet. But
that was intended for you, Bharat. That was intended for you, not for me.
So, gentlemen, let me share. So,
okay,
stop sharing, sir. Ashok Rajgopal, sir. So you stop sharing your screen. So,
okay.
Yeah.
Okay. Now, Bharat, you would like to show us?
Indeed. Here we go. Right. So, gentlemen, let us understand what has Ashok showed us in this last 15 minutes. He showed us a series of quite deformed and dramatic cases, different difficult clinical situations in which he said that he saw the PCL intact, and the incredibly talented surgeon that he is, he told us that he could keep that PCL there in place. That's one thing, a series of dramatic looking cases, number one. Number two, what did he tell us something more as part of his data presentation? He showed us that the PCL as a bundle of fibers, ligament fibers, seems to remain present even as years go by after having done a CR knee. What's the surprise in that? All the rest of the knee soft tissues around the replaced knee remain intact and present. So similarly, the PCL remains present. In fact, in that MRI sequence that he showed us as part of his study of whether the PCL goes away or gets attenuated or not, you will notice that the PCL was not at all in its functional orientation. What is a ligament? A ligament is a structure that has been created by nature as a restraint. A ligament, unlike muscles, is not doing any job if it does not remain in its appropriate tensioning. But we'll come to these details in a while. Most importantly, what did Ashok tell us? Ashok told us that, quoting Donald Rumsfeld, he said that there are unknown unknowns. The age gets them all, and it gets them even more firmly the more brilliant they have been when they were young. And I know I'm heading there, but Ashok, you have already reached there. And let me show you why I say that. Gentlemen, we know fixed bearing is the workhorse of total knee arthroplasty across the world. And as you cascade it down, the surgeon eventually comes to the point where he has to make a choice. Is it going to be a PCL sacrificing or a PCL saving philosophy that he endorses? Let me tell you honestly, I started off as a PCL retaining guy because I found that taking that less bit of bone away gave me a bit of more confidence in the early phase of my career. But I gave it up after doing maybe 1,000 or 1,500 knees, because as I became more experienced, I realized that, into inverted commas, balancing a PCL was actually a euphemism. I was actually destroying that PCL up to a point. The same amount of fibers, if they were compromised in the ACL, as an arthroscopic surgeon, I would seriously consider ACL reconstruction or repair. Whereas when it came to doing the same amount of iatrogenic damage as part of that anteromedial release, which Ashok told us, we talk about giving it that nice word called balancing. And we will come to this also in a few minutes. But let's start with some understanding of what the evolution of thought lines on this particular topic has been. As late as 1995, 85% of all knee replacements performed in the USA used this type of prosthesis, the PCL retaining prosthesis. As late as 1995, 85%. Gentlemen, look at this figure and remember it. In the healthy knee, the PCL, in the native knee, the PCL improves the quadriceps lever arm and aids in the femoral rollback. Whether these actions occur after TKA remains controversial. Formally, the PCL retaining prosthesis, the CR knee, was thought to have multiple advantages over the PS knee, and I'm using the word formally. These advantages which were supposed to exist were in the form of this list that you see: increased AP stability, improved proprioception, improved femoral rollback, and so on and so forth, including the last one, saves the bone a bit. However, this type of prosthesis fell out of favor to some extent for reasons such as some of those theoretical advantages were not seen in the clinical settings. Actually, let aside a femoral rollback, there are a few very definitive image intensifier studies which show that actually there is a paradoxical roll forwards. The femur slides forwards in a CR knee. Let aside. Why do you think the deep dish concept has now started coming in? But I'll comment on that towards the end of our talk. So, number one, it is difficult to balance PCL, especially in advanced deformities, either flexion tightness or looseness. Ashok himself concluded by quoting the great Johns, saying that surgery should be kept to its most simple form that one can do. And yet, he himself contradicted when he said that it is fussy. And of course, surgeons have to be fussy. And these are, Ashok, these are oxymorons in its in their strict meaning. You know, you are saying a contrarian statement within 3 minutes. And that's what I meant when I said age catches up with all of us. You know, since 1995 onwards, the trend has changed. And in 2001, only 46%, from 15%, 46% of TKAs performed were now PS knees. What you saw was from 95 to 2001, the component of total knee replacements done, from 15%, the PS climbed up to 46%. This is in 2001. Gentlemen, the reasons for the PCL substituting knee gaining grounds were, as you can see here, severe degeneration of PCL could occur after TKA, although I agree with Ashok that if that particular PCL ligament bundle is not stressed out by an overhanging posterior lip of a tibial component, etc., it will remain intact. I agree with him. Proper tensioning of the PCL is surgically demanding. Ashok himself acknowledged that yes, it is a fussy thing to tension it properly. You have to match the native tibial slope with the slope that you create when you put in a tibial component. And herein, gentlemen, herein is the key to the logic that I am going to offer you in a couple of minutes. Why do we have to? Why does Ashok say that it is important to recreate the tibial slope for every given patient to ensure that his PCL, that particular patient's PCL remains in an appropriate tension and balance? It is because, and he's very right about this, it is because every ligament, especially the posterior cruciate ligament, whose anatomy we will see in a moment. In fact, let's go to that. Oh, okay, we'll reach that in a moment. Every ligament is made as a custom-made organ for that particular knee. The lower end of the femur and the upper end of the tibia, they change from human to human and actually from one knee to the other in the same human. And each particular ligament, and the posterior cruciate ligament has 4 anatomical and functional bundles. And each one of these bundles is oriented so that that particular volume, the contour of that particular lower end of the femur and the upper end of the tibia, including the slope which Ashok mentioned, these are all a contributing factor to ensure that that ligament works as per what it is supposed to work, as per what all ligaments are supposed to work, which is that of remaining in appropriate tension through the range of motion of that given joint. Now we'll come to remember this point that I have made. Pathologies ranging from minimal deformity to major flexion contractures, etc., can be addressed much more predictably and logically when you do a PCL substitution, because now you are taking that ligament out of the equation. The very fact that you are going to change the contour, the volume, and the shape of the lower end of the femur and the upper end of the tibia means that there is no logic in keeping that ligament which has been designed for a completely different shape. The proof of the pudding, gentlemen, is in how we are eating it. Here, look at these statistics. Our own ISHQ's National Registry. I know it doesn't capture the entire country's data, but still, it has now got a humongous number of knees registered. I mean, the proof here is in front of you. More than 76% of Indian surgeons, if at all the people who have already given data are a representative section of our society, more than 76% are using PS knees. Not just that, let's now zoom out to the world at large. Trends in total knee arthroplasty implant utilization. Read the highlighted line. 38% of implants were cruciate retaining, 53% were posterior stabilized or condylar stabilized, and then there were others in the form of 3% highly constrained and rotating hinge, etc., etc. But the point I am trying to make is, over a period of last 20 to 25 years, increasing number of people have chosen posterior stabilized knees. Why? Not because they are silly guys that they don't understand, but they understand that it is a much more predictable and easier implant to handle. And whilst in the hands of a master like Ashok, anything could work, you know. But we are not talking about, this debate is not about whether Ashok is a good surgeon or an incredible surgeon or not, or whether Modi is a poor surgeon or not. This debate is about which is the appropriate design philosophy to adopt as a fraternity, which is the appropriate design philosophy which will take hold and take root as you go along in the years to come. And the proof is here in front of you. From 1995 to now, 2018, I'll go to the last, the 2018 one, but read the first line here. Another trend in TKA implant usage has been gradual increase in the use of PCL sacrificing construct versus PCL retaining constructs. That line tells you all. Let me go straight to this. And the other most important meta-analysis done for a second time. This is the second meta-analysis by the Cochrane Library in 2018, done in 2018. The first one was done in 2005, and now it is the 2018. You know what it says? The important thing we need to remember, gentlemen, whilst I am rooting for PS design, I will agree with Ashok, and I'll give it to my colleagues here, that the fact of the matter is the meta-analysis of the results, not of the usage of implant, but of the results definitively show that there is no serious difference in the clinical outcomes between the two groups of patients who have taken in with either a PS or a PCR knee. In fact, the statistical differences, although in favor of PS, the improved range of motion by about 2.5 degrees in the PS group in the Cochrane meta-analysis and about 7 degrees in the this other meta-analysis, both of them show that there is a statistically proven improvement in the PS group of patients. But the fact of the matter is that these improvements, whilst validated with statistical power, are of no clinical significance. What is the clinical significance of 2.5 degrees of an improved range of motion in a patient's life? So I will give it to Ashok that whilst the Cruciate retaining design seems to be independent of the fact whether the PCL is kept in or not, and whilst there is no serious difference in the clinical outcomes, as long as you want to apply logic, as long as you want to apply intuitive intelligence, it is quite clear that there is no point. Look at this particular diagrammatic representation of the cruciate ligaments. Look at that PCL, which shows those 3 of the 4 bundles that it is made up of. And all of us know the crossbar linkage model that allows the cruciate ligaments to remain tense appropriately. Here is that, here is a MRI scan. On the left-hand side, you see a knee where the ACL is intact. In other words, an ACL intact knee. And you know that one of the bases on which radiologists deliver their diagnosis of a absent or a non-functional ACL is the buckling sign of the PCL. A PCL cannot work normally once you take the ACL away. And here we are trying to even debate on this matter, whether a PCL is working in a knee where inevitably you have taken the ACL away. Now, Ashok, my dear friend, you need serious stereotactic brain surgery, as I show it here, to say that a normal anatomy, which is this complex, and in which the PCL is just a small cog in the wheel of a normal anatomy with the ACL intact and the contours of the bone as they are in the native knee, still working. Can any sensible brain call these the same, the lower end of the native femur and the artificial symmetrical components that we normally put in when we put a femoral component in and the tibial component in? Just by rearranging your slices in a manner to look like an apple does not give you an apple, Ashok. It just gives you something that might look like an apple. And only a delusional approach to it can make us claim that this is my original apple and that it works like an original apple. Gentlemen, although we have tried to reproduce normal knee kinematics in a replaced knee based on the early understanding of the normal knee kinematics, it is now generally accepted and very well proven that knee kinematics are more complex than initially described. I'll finish my talk with this slide, which Ashok also brought out in the last part of his talk, where he said the medial congruency. Basically, we are talking about the medial pivot philosophy. Why? Because it is now understood that even the femoral rollback that we talk about in a normal knee is not both the condyles of the femur rolling back equally. In fact, the lateral condyle rolls back far more than the medial condyle. The medial condyle actually does not roll back significantly. In most of our knees, we have symmetrical condyles, unless you have gone on and graduated to a medial pivot knee design. But 99% of the knees that are put in the world today have symmetrical condyles. They do not demonstrate, they cannot demonstrate the normal kinematics of a normal knee. To claim that leaving or PCL behind allows you a higher kinematic advantage, at the very best, it is the unknown that Ashok has fallen into. At the very worst, it is my friend losing his marble, man. And Ashok, whilst I'll still hug you, I'll give you the single malts that I have promised you. The mangoes will be delivered when you eventually make your godly appearance in this small forsaken city called Vadodara. But for the evening, let us together make sure that the audience get away with a real intelligent message, and not just a message which a very, very dear and incredibly respected surgeon whom all of us look up to has delivered in a moment of fallacy. and age. Thank you, gentlemen.
Thank you
Your
so much.
comments, Ashok.
Thank you, Bart. So, you know, every time there's a debate on CR and PS, remind me that back 2010, meeting in Gurgaon, I think, in Delhi, right? And Ashok put me as a moderator for Chit. Remember that time, Chit Ranavat. So he's always a PS guy. And I said, you know, why? And he said, look, here the audience, 70% of the Indian surgeons, they use the PS decal. But I said, yeah, but you know, for this is more forgiving, the PS. It's more for the junior. But once you get the touch arts, then you're gonna switch to the CR. Oh, he was very angry, but that time. But then since then, we are very good friends. And on his retirements 4 years ago, he invited me to give a speech on it. So that remind me always. So now we're going to start with this discussions. But before this, I would like to ask the panelists, how many of you are CR guys? Only Ashok?
In this panel, only Ashok, unfortunately.
Ashok, you don't have to raise both. You don't have to surrender. This is a sign of surrender, man.
Yeah.
And my feet as well.
And I'm going to ask Ashok first. Ashok, I saw your case is all very difficult cases. So how many percent or when is your indications that you use a PS?
No, the question is, when do you use a PS?
When do I use I do not use a PS.
Never
I do
ever?
not. I do not use a PS. If for whatever reason we have to take down the PCL, I will go to a medial congruent design. So I will still keep my CR knee, CR femur. I will use a ultra congruent or a medial congruent design. One of the points that I wanted to actually bring out here is, if you look at the recent figures, I don't have the source, but I can find that and let you know. Today, currently, as we're talking, your figures are from 2014. And I concede at that point in time, PS outnumbered CR by a long way. But the interesting thing in what you presented was the steady rise. Of course, initially everything was CR, and then of course it took a beating. But that was largely because of the kind of designs that were available. They were flat on flat designs. There was polyware. The polys were oxidized in air. They were oxidized in oxygen. They were not the greatest polys in the world. All your PS designs were basically deep dish. I mean, what you're talking about, these congruent designs, is really what your PS is. But then it came on the back of the polyware, the clunk, the wear on the posterior impingement, dislocations. You mentioned a very interesting point about paradoxical movement. You also mentioned correctly that no replaced knee comes near a normal anatomical knee. It does not. I concede that. PS also has paradoxical movement, and you talked about the excursion being more on the lateral side. Great point. We talk about the medial pivot knee, right? If you look at the work from people like Scott Banks, they actually talk about the lateral pivot knee. And they say that when you start your flexion from 0 to 30, 35 degrees, the pivot is actually on the lateral side. From 35 to 90, it comes more towards the medial side and then shifts posteriorly. There's a lot of debate on that. So there's no absolute conformity or total agreement that all your knees are actually medial pivot knees. We like to believe it. Most of the companies are coming out with medial pivots. Your instant center of rotation, your divot point, your dwell point are all on the medial side. Consider all that. But it is, I don't think we have seen the end of it. Finally, I would ask you, why is research going towards customizing knee? When you look at the knees that are actually custom built for patients, prohibitive expenses, take all of that aside. Why are we going towards robotics to try and reinvent the original anatomy of the knee joint? You're talking about having different knees. Yes, your right knee and left knee may be different. Mine may be. My knee is going to be very different to Parag's. And I think time has come with development that you cannot be harping on the same thing and say, take the PCL down. Sure, take it down. But make that a functional knee, and to have 1.2 degrees, how do you even measure 1.2 degrees? And how?
Yes,
Ashok, so if I could respond. Ashok, I agree with you that research and pursuit of further evolution of ideas should go on as part of any scientific endeavor, and certainly besides being, carpentry oriented, we certainly are a group of people who have scientific bents of mind. So to explore those cruciate retaining ideas, etc., is very welcome. As experienced surgeons, as designer surgeons, as people who have actually molded to some extent contributed towards the molding of pathways of practice in this area of work, we know that some of the, into inverted commas, innovations are also a push for two reasons. One is the personal adrenaline and ambition that we as scientists have to try and contribute something new. And second, industry needs to add some bells and whistles and innovations as older products go on off patent. And therefore, they need to bring in something a bit different and add value to it, whether true value or perceived value. So I'm being very honest here when I say I don't want to stick to an old idea sort of thing. Genuinely, it is important for the wide. I know Ashok is my guru actually, so I have learned from him over the years, and I don't want this message. It is not meant for actually this panel. This message is meant for the wide audience, younger generation people who might feel that PS or CR. The take-home message should be that clinically speaking, as long as you don't botch up your, see, for example, I think what Ashok showed us about the joint line accuracy, what he meant was, it's not that the CR knee gives you more joint line accuracy. The CR knee needs more joint line accuracy. The bicruciate retaining knee does not even allow you more than 1 mm tolerance of the recreation of your joint line level. So whereas a PS knee gives you the tolerance of 6 to 9 mm. And this is not my slide. This is Ashok's slide. And that slide was not about the ligament retention allowing you more accuracy or automatically offering you more joint line accuracy. It was about the need of that particular joint line to be accurately leveled if you had one of those three options, depending upon which option you took. And that actually proves my point to the larger audience. Go for a design which is easy in terms of the ability to reproduce. Reproducibility is the key to a repetitive exercise. Reproducibility and knee replacement as a genre of surgery is a repetitive exercise. It's not like brain tumors, which is almost customized every time a neurosurgeon goes in. Knee replacement is, as a procedure, lends itself to the human race as a repetitive exercise requiring to improve upon the disability that the patient has had. And in that sense, PCL sacrificing design philosophy, which now has also corrected its shortcomings, like the clunk, like the size of the box, the amount of bone that is now required to take out with the new designs, as you know, Persona, Tune, all this, is a tiny, tiny little amount of bone now. And in fact, one of the smallest amount of bone that I take out is when I do an Indus knee, and it's fantastic. It just gives a, and that your femoral rollback, now that we have understood it, the importance, placing that cam, the spine on the tibial insert a little bit back, and it gives you that extra rollback and therefore that extra, flexion ability. In fact, the last, Ashok, the last review, the Cochrane one is a 2018 one. The 2014 trends was the 2014, the trends wala paper. but the Cochrane was a 2018 one. And whilst there will be some resurgence, I'll conclude in half a minute. Whilst there will be some resurgence because of the deep dish design, please let the audience understand that the deep dish design is not about CR. The deep dish design is a philosophy where it is a ligament independent design. Whether you have a CR, whether you retain the PCL or not, the deep dish design gives you the stability by virtue of the building up of the anterior lip on side. So that and PCL retention or PSCR has no real correlation in this debate. The deep dish design is just one more piece of design approach, one more option of design approach. Yeah,
All right.
Nico,
I have, you know what? You cannot tell, but this is my experience. So if you look at the data of this joint registry in Australia back, Chris Fairtool, I think in 2017, in Holland, we did in 2019, we published it. And in Norway, just recently come out, the joint registry shows that the CR, for example, in Holland is 1.5 times better. In Australia, it's about 45% better. So, you know, it's joint registry. Can you debate on it? Yes, Ashok.
So, Bharat, I wanted to make 2 points here, 2 corrections, if I may. Both, when you talk about joint line accuracy, you're actually talking about the joint line level. Yeah. Now, I concede the fact, and Parag and I, we've had several of these presentations. Does joint line really matter? Particularly in the revision situation, does it really matter? And I think if you look at enough data and you look at, you speak to people like Bob Booth or Kelly Wins or Mark Hartzband or the Mayo Group, Alan Hansen's work, this is a misnomer. That joint line level is basically a misnomer. It's not a line, first of all, it's an arc. It's an arc of movement. The second point that I wanted to check with you is when you talk about the deep dish designs, they are very different philosophies. If you look at the Zimmer philosophy, which is the persona philosophy, you have to empty out the intercondylar notch and then use your UC or the MC concept. Versus if you have to use the same thing in, say, a Smith and Nephew construct, then you do not. You can still have your PCL it is mandated in a persona that you have to empty out that. So there's little different. The reason for that is the dwell point.
That is what I'm saying. A deep dish design is actually called a PCL independent design.
It is independent. Yeah, it is not. It's not PCL dependent. You're absolutely right. But it depends on whether you have to retain it or you have to sacrifice it. Yeah. And the point that Nico mentioned is actually correct, because and this is completely an unbiased opinion. The bottom line really is, like you rightly said, Bharat, it does not make any difference whether you do a CR or you do a PS. You do it well, you balance your ligaments, you believe in whatever philosophy you have to. So this, my presentation is not a hard sell to people to say you have to do CR. If you're happy with the PS, by all means do go ahead, because this debate has been happening since the 90s. Yeah. And it has been going on and on and on and on. And I remember at the ROC, the way I've got bashed around, and I always used to get CR, and I always used to usually have to take on the big man himself. And much as I tried to stand up, it was having 98% of the audience against me, and 2 guys, when the question was asked how many CR surgeons, I used to lift up both hands and both feet. That made 4 of us. But for the rest, and I think Nico is absolutely correct. But for the most part, but even, my point is, over the years, even they have mellowed down. Kelly Wins is now a CR surgeon. Believe it or not, he does not do PS. And there are other people from the same stable that you're talking about. Parag knows who I'm talking about. They're 70% CR surgeons. So I'm not castigating PS. Please don't mistake me. And this message to the audience at large is not that PS is bad. PS is fantastic. It's a great knee. Both are bad because neither of them comes anywhere close to normal kinematics. You are doing a compromise. If you have to do a really good knee, I believe at the moment, and this is completely a philosophical statement, not based on any written or clinical material, you should put in two unis. Put in a medial uni, you put in a lateral uni, have differential heights on the medial side and the lateral side, have different rotations because your medial construct is different and your lateral construct is different. Your cuts on the tibia have to be different. If you can do that and you're good enough to do that, you will have those patients going on to 20 years running, playing golf, skiing, doing triathlons. And the classic person and case and example is Sergio Romagnoli. I mean, Sergio has a 24-year survivorship of 97% with two unis. So at the end of it, whatever you do, unless you're retaining both your cruciates, you're getting a rollback, you're getting your slopes, and the slopes are differential. Your lateral slope and your medial slope is very different in your knee and my knee. So whereas in a total knee, what are we doing? We're creating one platform and we're trying to balance. So I think basically the whole philosophy in a very stupid sort of way it's a misnomer. But what we're trying to do is we're basically resurfacing something, creating an ambience or kinematics within a soft tissue envelope, which is at completely at variance to what you're trying to put in. And you have 6, 8, 10 sizes, and we're expecting those 10 sizes to fit 20 billion people. It doesn't happen like that.
Yes, Parag.
Yeah, so I think it was an excellent debate. We have about 10 minutes for some question answers. But before we open it up to Dr. Kailash, Dr. Sunny, and I also have a couple of questions. I think it will suffice to say that whatever is good works in your hand, you should do it. But at the same time, I picked up a lot of points from Dr. Rajgopal's talk, and I think people have moved to CR. Bharat, it's not that I'm taking Dr. Rajgopal's side, but I've seen a shift, and there are certain people who we know who have moved away and are quite happy doing CR knees, and it's ultimately the experience what you have. For me, I'm still doing PS. I've never done a CR knee in my life yet, but I also am thinking, the smaller knees, because the Indian sizes, sometimes you have to put a size 2 or something, and then you're removing them too much of bone from the box, so it may be an issue. So I myself am thinking to try some cases, and I think it's it's a process of evolution. You do what works well in hand, and if I do a few cases and I like it, I'll go on. And it's ultimately what you're trained in. So I have been trained as a PS guy, so I've been doing PS. So let's see where it goes. And I think the last statement what Dr. Rajgopal made was, he's absolutely right. The bicruciate retaining knees have a promise, still in its infancy, but a lot of work is going on. We are aware of it. But once it comes, I think that will be the thing to watch. And
Parag, yes. I just took out. Do you believe in this joint registry or not? Because it tells a lot. I mean, like in United States, the joint registry is that, because a lot of the surgeons, they are the designer. So I mean, like when you design the PS, like me, I'm designer of this middle pivot. So I said middle pivot is now the in. I mean, you understand what I mean? But registry, like in Holland, like in Norway, like in Australia, it shows that, yeah, Bharat.
Yeah.
Nico,
so,
yes.
Nico,
Yeah.
just a moment. Including the registries, the Cochrane analysis of 2018, it has distilled its data from 2,816 reports comparing PS and CR on all parameters: radiological, functional, clinical, survival, in every sense. The Cochrane analysis, along with that other meta-analysis that I showed, it covers as comprehensively as the world data can offer itself. What you are referring to are individual registries. These people have taken those into accounts, all published reports, analyzed it, applied very complex statistical validation tools, and then have come out with this particular conclusion that although there is some statistical significance in the improved range of motion and it's a little bit here and there in the PS group of knees, the fact of the matter is it doesn't make any clinical difference. So I am myself saying that there is no basis in terms of clinical results to root for one or the other. All I am submitting for your consideration is choose a methodology. The vast majority of us are good, competent, average, maybe a little bit above average surgeons. Why do you want to make life complicated for you and your patients? If you can have a bloody simple shortcut, why do you want to take a detour?
Okay.
And that's the simple message, man.
No, that's right. So, a lot of people, the young guys are watching this, webinar. So one question to Rajgopal sir, you spoke about this ultra congruent and you spoke about deep dish designs and the medial congruency. Can you little bit elaborate more on how these work? And, what is the current status in terms of their use as of today? A little bit of the way it works, the kinematics, and then its current status.
Right. So great question, Parag. So basically, the concept of these deep dish or ultra congruent or the middle congruent is not new. This was really developed from the philosophy of Aaron Hoffman from Salt Lake City.
Exactly.
And he came out with, because he was a CR surgeon, and he had, back in the 90s and sort of early 2000, he had issues with the PCL. So to get stability, he devised this deep dish which had an anterior lip, which actually prevented the tibia from going back. It was like a sort of a check rein, a little bit like what the meniscus does. That was, well, it worked very well. And if you look at the natural knee, which is one of the more popular knees, it's just been recently discontinued by Zimmer and Biomed Group. So the ultra congruent was really a developmental sort of next prototype for that. The issue with the medial congruent is it's got a little blip at the back, which does the same thing that the post does in the PS, and it actually hooks to the back of the femoral component. The problem is that the contact area between 30 to 90 degrees of flexion, which is where you need your most stability, the area of contact was better than a conventional CR or PS, but was not really that good. And because of the congruence on the medial side, the amount of rollback that was happening on the lateral side was not as ideal as we would have liked it to be. So this was then further developed. The dwell point on the medial side was taken further back, and the lip was taken a little higher on the medial side, and it was sloped towards the lateral. So what that did was effectively allowed the knee to go into flexion with a pivot on the posterior part of the medial condyle, and with an excursion of between 3 to 4 millimeters medially and between 7 to 11 millimeters. It's almost a centimeter of shift on the lateral side. So that allowed for deep flexion. And we've been using this now for the last about 6-8 months. And you get very comfortably, at least on the table, you get 140, 145 with excellent stability and congruence. And then the good thing is you don't take out any box. I take the point that Bharat made, that nowadays most of the newer knees take out very little box, whether it's the Indus or it is the Attune or the Persona or even some of the newer.
All of them.
All of them take out less. But my question is, why take out anything at all, Bharat?
No, I'll tell you, you take it out if required. As for example, the ultra congruent design, as what actually Ashok has just described to us is the evolution of the ultra congruent deep dish design from initial Aaron Hoffman's presentation. And I remember I saw it for the first time at the CCJR maybe 25 years back, 24 years back. So it's that old, this concept, it's nothing new. But it was a symmetrical ultra congruent design. Unlike now, the medial congruent persona thing that Ashok has just described, and the medial pivot knees, which have already been in existence again as a design philosophy for the last 15 years at least, but they didn't, for some reason, they didn't take off. And it's only after more and more people started realizing the work that was offered by Pinskarova, Wroblewski and Pinskarova being a lady, Hungarian lady, and Wroblewski, the great man himself. These two people used MRI to show how a knee achieves deep flexion to the point where the medial side actually does not do a rollback after the initial rollback, and then it just rotates. And it's the lateral condyle which keeps on doing a rollback to the point of subluxating off the posterior lip of tibia. In fact, the mobility of the lateral meniscus is now understood that nature has provided that mobility so that it allows the lateral meniscus to almost slip off the posterior lip of tibia. And that is why what Ashok has just described to us, that the lateral side of the tibial plateau is almost, 1 centimeter. It allows a 1 centimeter roll back, whereas the medial side is a congruent thing, which does not allow the medial side to roll back. And that is what then allows that, or it is as close to imitating the natural knee deep flexion movement as is possible in a prosthetic combination construct, So anyway, but this is a different philosophy altogether.
Yeah. So I think that point is well made. So just one quick question is that, so if we want to use ultra congruent, should we use it on a regular basis, the deep dish design, or just keep it as a backup, in certain cases where you feel the PCL is not good and you want to, give a little more stability to your construct? So what is the indications, for a person who wants to use an ultra congruent or a deep dish design? In short, what would you say?
So if I can volunteer there, if I had to use it, I was using a CR knee, and can you hear me?
Yeah.
Sorry, can you hear me?
Yeah, we can hear you, Bharat.
Yeah, we can hear you.
Okay, so when, as I told you earlier in my talk, that I used to be a CR guy early point in, and this deep dish design is not a new thing. It's been there for a very, very long time. And I used to request my dealer to have a set of deep dish inserts available, because in a modular metal bag tibia, if you end up not feeling confident about your PCL being the integrity of your PCL, instead of migrating to a PS knee, which required some additional steps, and in your early phase you are a bit not sure whether you want to migrate to the cutting of the box, etc., you can still come out feeling very comfortable and confident if you just, instead of using the regular insert, you use the deep dish insert, because it sits the same way as it does on a tibial tray. And you don't have to do anything different. You don't have to take any additional cuts. You can change your insert even after cementing your femoral component and achieve your stability if you got worried about your stability after cementing your femoral component. So deep dish design is one time that I would use if I was doing a CR knee and wanted. But now the advantage is, as Ashok has told us and educated us, that with the modern deep dish designs, you can embrace it with the idea of actually changing your entire approach towards the biomechanics of your replaced knee, which is, giving it more flexion. In fact, the traditional deep dish designs Aaron Hoffman's design could not lay a claim to higher flexion, because the higher lip height would actually, according to Johan Bellemann's demonstration, had the risk of hitting or impinging on the posterior femoral cortex, and therefore coming to a stop as far as flexion was concerned. But the modern day deep dish designs are a bit different, and there they offer certain more advantage, at least in a biomechanical, kinematic sense, as compared to the old ones.
Yeah. So, any other questions, Kailash, Sunny?
Yeah. So I just want to point out now, if you look at the lineage of how the knee has been developing, it started initially with just a surface replacement, retaining on the ligaments, coming down back to cruciate, substituting, and it's going back again to retaining the cruciates again along with these new developments. So it's going more towards what we had initially started off with. Do you see in the near future, as Dr. Parag also pointed out, that it's still in its infancy, that we are retaining both the cruciates and maintaining the kinematics as per what the original knee is? So do you see it going towards it, or we will be, because in between there was a long time period where cruciate substituting were quite doing well, and they're still doing well. And I mean, is it going towards retaining, or is it going back towards, or it's that trend is that waxing and waning is just going to go on?
Yes. So just to rephrase these questions, are we moving towards a bicruciate retaining knee, Rajgopal sir?
I don't think so, Parag. I think it's very early days yet. It's a very attractive concept because obviously your knee and my knee has both cruciates and it functions well. The challenge with retaining both cruciates, and I'm sort of in a way privileged because I worked on developing ACL PCL retaining knee, which actually went out of it was actually abandoned. The biggest challenge is keeping that central eminence. It just used to pop out. It is the easiest. The minute you extended that knee, it used to pop out. And that's really what is happening with most of the modern day designs. So there are very few surgeons who are extremely skilled. And this is where robotics and your newer technologies are actually coming in, because you're milling that part, you're getting your slopes. The challenge when you retain both cruciates, like I mentioned, is you have to have differential slopes on your medial and lateral side. You have to have different insert sizes on the medial and lateral side, because as we all know, your lateral side is convex, your medial side is concave, your slopes are different on the medial and lateral side. When you do a TKR or whatever design, you just knock it off, 90 degrees or 5 degrees of posterior slope, end of story. With a retained cruciate, you cannot do that flat concept. Now you are looking at going back to the 4-bar linkage. So it makes the whole thing a whole lot more complicated. When it works, it is brilliant. And like I said, some of the European surgeons, this is not very common in the US or in Canada or in Britain, but in Europe, particularly in France and Italy, they are great advocates of putting 2 unis. And so I know a couple of surgeons, friends of mine, who actually put 3 unis. They put a patellofemoral, they put a medial compartment, and they put a lateral compartment. Now, technically, you can turn around and say, why do all that? Why not just do a total knee? The reason is now you have a retained cruciate. You have your ACL, your PCL, you got your patellofemoral, you got your medial joint and the lateral joint. So effectively, the answer to your question is, ideally, that is where we should be, because that is the future. Will we get to it? Certainly not in my lifetime, I don't think. I'm at sort of almost at the tail end of my career, but maybe that is the future, and combine or marry that with artificial intelligence, robotics, milling. Who knows? That may be the future of where we're all heading.
Kailash, if I could give my opinion, the fact is, I understand what Ashok is saying, but if I have to make a comment, it will be a stark different comment. In the sense, I think it will never be the future. Why? Because it is too demanding. It is too complex. Again and again, I'll bring home the audience and our discussion to the central focus of what this procedure is supposed to deliver. This procedure is supposed to deliver an improvement in your clinical performance of a damaged knee. And you will find that even if so it will be practiced by few enthusiasts, maybe practiced by very talented surgeons and experienced surgeons, but they will be tiny, tiny numbers, which will be good enough for discussions in academics. It will be good enough to write a paper here and there, but it can never take off as a mass procedure. And therefore it will not be future in that sense. It will always be around. Yeah. It will always be around, but it will not be.
Bharat, you should have an optimistic outlook to life.
Am I optimistic?
At the end of the day, when you look at where we started off from, 90 degrees was good, then 120 was good, then 150 was bad. And I think, when you look at the unhappy knee, people at 110, 120, you look at Phil Noble's work, you look at Peter Sharkey's work, all of them, we are trying to get towards normalcy. It is like your Maruti 800 worked very well, but then it progressed, right? So this is an evolution.
Could be.
Like I said, 30 years from now, I can promise you, none of us will probably be around to see that, but I can almost guarantee you that this will not be the knee of 30 years from now. So I think it's a phase in evolution. I take your point. Right now, possibly, For the majority of patients, it will be a conventional total knee, whether you sacrifice or retain your cruciate, whichever your bias is. Take your point totally. But moving forward, I think the human mind, the demands of patients, when you and I, certainly when I started off, any patient below 70 never got offered a total knee. Today we're doing total knees at 45 and 47. They're the baby boomers, they're obese, they're aggressive, they want to run, they want to play tennis, they want to ski. So I think somewhere you are factoring in the expectations from patients, meeting patients' expectations.
Could
So
be. I take your point.
this is towards that. Not going to happen tomorrow, but this is possibly where we are.
Yeah.
Fair enough.
So-
I take your point. And
One last
I
question from Sunny, and then we hand over to Dr. Nico. Yes, Sunny, you have any questions? I don't know, his screen has frozen. Yes, Dr. Nico.
Yeah, maybe Ashok, can you regarding the CR, can you give some tip and tricks, because there's a lot of young surgeons here. What is your tip and tricks? Because you know that you retain the PCL, and by the time it will worn out. So maybe you can give a very good tip and tricks. How do you do that?
Okay, great question. I'll tell you, Nico, how I do it. The first thing is when you've exposed your knee, whatever approach you use, the first thing to do, if you are going to be doing a CR, look at your intercondylar notch and clear your intercondylar notch, because that is where your cruciate belongs. Most advanced arthritis that we see in our part of the world has lots of osteophytes that impinge, and by the time you've actually done your resections, you've probably chewed up. So as a step, the first thing we do is we take down the marginal osteophytes on both sides of the intercondylar notch. I finish my femur. I'm a femur first surgeon, so I don't do the distal femur and proximal tibia. I don't do the proximal tibia first. I finish my femur, then I do my tibia. So for me, after I've done my femur, I will go back to the back of the knee, take down the posterior osteophytes. So at the end of it, I have a pristine intercondylar notch. I have taken down the posterior osteophytes, the peripheral osteophytes, and now my femur is ready with the correct rotation aligned to the transapicondylar axis or whatever. I will then take on the PCA, the tibia. I will always look at the lateral view and align my slope depending on what a true lateral view looks like. Come as close to it as possible. Limit the amount of tibia that you, the more severe the deformity, less tibia you remove. So at times with 30 degrees of varus deformity, I would take out maybe 4, 5, 6 millimeters of tibia. Remove the peripheral osteophytes, and then I typically balance my knee by using the trial components and putting my femoral component. I leave it a little loose, and then I check my range of movements. I make sure that the tibia does not rise up as you go into deep flexion, because that indicates that there is a PCL tightness. And if you do have that tightness, very often it's because you've left a little bit of the osteophyte right at the back of the knee. You go back in and you with a rongeur or with an osteotome, you take that down, you suddenly decompress that osteophyte, the PCL looks good. The intercondylar notch looks, it's just filled up with the PCL. You can see the two bundles of the PCL beautifully. And my sort of premise is that you should be able to take that knee down to 125, 30 degrees without the anterior tibia lifting off, the so-called polo test. You should not be able to move it back and forth with the pedal line position. If you're able to do all of this, then you have a great, very well-balanced PCL. The last point is you balance your medial and lateral structures. I also recommend, and I practice this myself, you balance your PCL with your patellar tendon. So at 90 degrees of flexion, your patellar tendon and your PCL needs to be parallel. If you can demonstrate that parallelness without your anterior part of the tibial base plate lifting up, you have nailed it. You're absolutely nailed it. And then, of course, your patellar tracking needs to be, where it belongs. That tells you your rotation is correct. And so that's my procedure for that.
Yeah, but Ashok, when I saw your valgus knee, that you keep the PCL there, but when you cut the PCL, it will rotate back. So that's like Paul Lotke say, why in valgus knee they prefer to have a PS instead of a CR, but you don't release the PCL at all in your valgus knee.
No. Nico, let me be very honest. I won't say I don't. Very severe valgus knees, I will release the PCL. So I like I said, 95 times, the 5 times it's always the valgus knee. Valgus knees are difficult knees. And if they are really, the challenge is, sometimes when you're releasing that posterolateral corner, and we actually had devised a technique, and we've described it, we published this also. If you can internally rotate your tibia with your trial components, with your tibial tubercle going beyond the sagittal plane, if you're actually able to do that, that means your release is adequate. So that's really what we bank on. And once you do that, the other point with valgus knees is you have these lipped osteophytes. You take a ronger, you put your tibial base plate and take away all the excess bone. That decompresses it beautifully. And again, we take down 5 to 6 millimeters, the more severe the deformity. And I won't say all the time, but I think 80–90% of the times, even with severe valgus knees, we are able to put in a CR. We published our 15-year data on this. But having said that, I don't think we are stuck on retaining the CR, the PCL for every case. If it comes to that, if we are struggling, we would not hesitate. I mean, I have put in a CCK, LCCK, or RH. I mean, we do the LCCK. We are very happy to do it. But as a concept, our first bias is to try and save the PCL if it can be saved.
Thank you. Bharat, can you tell us, you have a lot of tips and tricks. I learned also from you how can the patients, my Indonesian patient, because in Europe we don't need to have more flexions, and thanks to you that time. So can you give a bit tips and tricks for the young surgeons? How to get more flexion or inpatient recurvatum, or can you tell us?
Sure. The one thing which anyone who is going to adopt the CR philosophy, Ashok has already said, the key is in recognizing that you don't leave your PCL in excessive tension. Otherwise, it's going to crush the posterior 1/3 of your plastic earlier than what otherwise it would. Remember, the lift-off that you see is on the trial stage of this surgery. The moment you cement your actual tibial tray in and put a insert which is locked into the tibial tray, now you won't get the lift-off. Now, actually, what you will get is building up of the pressure on the posterior 1/3 of your plastic, and that will lead to early failure. So on the CR side, the tip, in a sense, a warning, is to make sure that you balance your PCL appropriately like Ashok does, so that your CRs will last long, otherwise they will not last long, number one. Number two, the tip for PS knee. As far as the PS knee is concerned, that is one of the merits that it offers itself vis-a-vis the ligament debate, which is what the main subject today is, that the moment you take your posterior cruciate ligament away, it releases a very strong restraint between the two bones, between the two protagonists in this entire drama, which is the femur and the tibia. And now it's your design which allows you to establish the relationship between them. As long as you do all the other things that Ashok has already described in very superb details, I think you will get a very, very good flexion in a PS knee, which is also seen in the meta-analysis results. But having said that, the patellar tracking, if the thrust of your question is for achieving deep flexion, especially in Asian populations, which is what you said, in Indonesia, that helped you give a higher level of satisfaction to your patients. This is the one thing that I learned and which I have talked about extensively over my career, which once again, as I say, all of us are, well, not all of us, sorry, but led by Ashok, I'm very close behind. I mean, we have done our work, and my message would be the key for deep flexion, consistent achievement of deep flexion is in balancing your patellofemoral joint, which is very rarely talked about. Balancing of the patellofemoral joint, and how do you balance it? It's a subject of a different seminar altogether, the subtleties of it. but that is the one joint that keeps on getting missed out in terms of close scrutiny or adequate allocation of time to understand the impact of that joint, both in terms of plastic survival and in terms of avoiding anterior knee pain in the post-op situations, and third, in achieving deep flexion. All these three things are directly related to the patellofemoral joint. So the tip I have for the youngsters is to understand the PF joint in a knee replacement situation.
Yeah. So I think we are nearing the finishing time, or in fact, we've crossed it a little bit. We are over now 95 minutes into this webinar. A lot of learning, I would say, a lot of new concepts, a lot of tips and tricks, and a lot of information was there. Nico, you want to, conclude, and but before you conclude, may I ask Dr. Ashok Rajgopal and then Dr. Bharat Modi to just give 3 lines of, some message, and this is a debate. So, Bharat made it interesting. Dr. Ashok Rajgopal made it interesting, but ultimately, it's a question of what the viewers perceive, what is their practice, what is works well in their hands. So, Dr. Ashok Rajgopal, can you just give a very short message, as a conclusion, so people go home with a message?
So, great final point, Parag. The only message I'm going to give is don't get hung up on CR or PS. They both work. Learn the philosophies, and both, the two gurus of knee replacement across the Atlantic, Dr. Chitra Nawat and John Insall, they basically focused on just 2 things. Balance your tissues, get your medial and lateral structures intact, get a good bed, get good cementation, use good joints, whatever good joints means to you. Now, if that is a CR, so be it. If it's a PS, so be it. The last point is, do not compromise on principles, and do not compromise on a lot of the issues that has been discussed at length today. At the end of it, you have to remember you're putting something which is completely alien to the human body. It's never going to be the actual knee. You come as close as you can, and as long as you can give the patient a functional, painless, mobile knee that allows him to or her to do their normal activities of daily living, I think you've done a great job.
Absolutely, absolutely. Dr. Bharat, your message?
So, Parag, in fact, Ashok has already given the message that any senior experienced surgeon would like to impart to the next generation. I'll just add a tiny little bit, which has nothing to do about the surgical technique. It's about the approach to your profession. And what I would say is for the next generation, of course, as Ashok said, keep an open mind. Be ready to try new things, but don't turn it into a religion that just because you think it's something new, it's progress. So that's a lot of youngsters will end up thinking that something new will be equated with progress, whether it be robotics or whatever. You will find in due course of time is a great leveler, and it will allow wisdom to come in. Knowledge, information gives you excitement. Digesting that information gives you knowledge. But real understanding, allowing time to pass by and seeing whether there is real, advantage to this extra effort in whatever sense, money, time, blah, blah, gives you wisdom. So young gentlemen, whosoever is part of this evening, that's my message to you. Whilst all this surgical technique is absolutely a given, you need to have all that. Far more important as you go across a career will be this aspect: information, knowledge, wisdom, this gradient.
Perfect. Thank you so much. Over to Professor Nicholas.
Yeah. So I hope that this debate, we learn a lot for the next generation. We have the 2 master, world-class faculty, world-class speaker, but also they are very good surgeons. Some surgeons in United States or Europe, when they talk like this theory, but then how many patients they operate, what is their experience? Look at Ashok and Bharat. They operate more than 30,000 a knee. It's amazing amounts. So you learn from the master himself. So by the end, I would like to conclude by saying that what Chit Ranawat always quotes, that for the young generation, for the next generation, that any technique done by a surgeon who truly understands the basic principle give an excellent result. And the most sophisticated involves instrumentations in the hand of the cookbook surgeons can be disaster. That's all. Thank you, Pak.
Absolutely.
Thank
Thank you. So I think it's time to conclude this webinar. I wish to place on record a sincere thanks to Dr. Kailash Patil and Dr. Sunny Gugre for putting this together. And of course, Ashok Sham, who is always working relentlessly behind the scene and putting this information to all his viewers. We will know in some time how many people were there. We will let you know. But Ashok, thank you very much. And we are really very thankful that you could organize this and send it to all your viewers. With this, we will conclude this webinar, and we will have the next APAS webinar after 2 weeks. Professor Nicholas will discuss and then choose the next topic. But thank you so much, Bharat. Thank you so much, Rajgopal sir.
Thank you all.
I'd like to end by saying one line.
Bye, all of you gentlemen.
Thank you. One line, what Dr. Rajgopal said, never compromise on principle. I'll just add, may it be orthopedics or otherwise. Never compromise on your principles.
Thank you.
Thank you. Thank you. Bye-bye. Bye-bye, everybody. Bye.
Bye.